In a little later, yeah.
Yes, sure. Good evening, all of you. Myself, Dr. Shubhangi Dere. I'm psychiatrist at Navi Mumbai Kharkar. It's my privilege to moderate this session today. So this is a Child Psychiatry Subcommittee of Psychiatric Society of Western Zone under leadership of Dr. Manjiri Deshpande and guidance of Dr. Pangavkar sir and Dr. Bhushan Shukla sir. The committee has been organizing a lot of wonderful sessions, very important, insightful topics in last few months. And in the same series, today we are going to have another interesting topic, which is very important in today's world, especially where the technology is taking over all over the life, and managing the sleep has become very difficult for everybody, especially in the children. So the today's topic for discussion is management of sleep disorders in children. And to deliver the talk, we have a very eminent psychiatrist specialist in the field, Dr. Sapna Bangar, who is specialized in child and adolescent psychiatry from UK. She's completed her undergraduate training and postgraduate training from Nair Hospital. And before going for the certification training in UK, she was awarded a Fellowship of Royal Psychiatrist of Society in 2009. And after relocating to India, after her training and work in the UK, she's been serving in the field of child adolescent psychiatry and management of mental health issues in young adult since last almost 20 years. And her keen area of interest is the same, and her focus is on delivering evidence based practice in the same field. So it's our privilege to have her, and I'm sure everybody is going to benefit with her expertise. So I welcome all of you for the session, and over to you, Dr. Sapna.
Thank you, Dr. Shubhangi. Since we are a small audience, I hope that it is interactive and people can ask me questions as we go along. I've tried to keep it as practical as possible. So a little bit of theory, but also what we can do in our daily practice. Because sometimes it is difficult about how do we manage, because a lot of times people tell me they don't have the time. As child psychiatrist, I think we have the luxury at least of seeing patients or children for longer. So our, my first appointment is usually about 45 minutes to an hour at least minimum. But I know that a lot of people don't have that kind of luxury and have shorter appointments. So I've tried to keep it as practical as possible. I'm just going to share my screen and then we'll start the presentation. Here we go. Okay, so the topic was a clinical update on sleep disorders and their management, specifically in children and young people. And the aim of today's session was to be able to recognize and differentiate whether this falls under the normal spectrum. Is this something to be concerned about when children complain of sleep issues? And the practical treatment aspects, especially considering that it is young children, and what is the evidence base for that. So usually when children present with irritability, inattention, aggression, academic difficulties, poor school performance, I think especially in a busy OPD, like when I used to work in Nair, we used to hardly ask about sleep, because we don't have that luxury of time. So I think in a busy OPD, it's very difficult, but I want to emphasize that it is, especially in children, it is very important to make it a routine practice to ask about sleep. And why, as psychiatrists, why should we bother about sleep? Why is it so important? Especially in children, what happens is that we know that it has a huge role to play in cognitive functioning. So even imagine if you've not slept for 2 or 3 days, we all present with we are not able to pay attention in probably the OPD. We have memory problems, there's problem solving issues that crop up. In children, especially, they come with a lot of irritability, behavioral issues, they have mood problems and hyperactivity. So a lot of times, especially with only the sleep issues, there is a lot of misdiagnosis with ADHD because they are unable to sit in class and concentrate most of the times. I have seen children like that who are unable to concentrate in class, And often that why the teachers refer them to us is because this child is not being able to sit in class, or is like, constantly fidgeting, or it is they are not being able to grasp what is happening in class. But simple things about, like, if they have chronic sleep issues, they might present as this presentation. They have a lot of problems with emotional regulation, just those who don't have a proper sleep schedule. There's increased emotional sensitivity. They're very, very, like, they might cry very easily. They might get very irritable. They start hitting other children. And they have difficulty in managing stress and emotions in general. If it goes on for a longer period of time, it might also affect their growth, learning, and overall maturation. We also know that sleep issues now, especially lifestyle changes and lifestyle disorders, have taken a huge impact. We see a lot of children in our clinic who are coming with obesity because of lack of, like, because being on the screen all the time, not having enough physical activity, and then lack of sleep. It is almost like, a disaster waiting to happen. They also come with childhood diabetes, hypertension, heart disorders, and the propensity for all of that is very huge. Poor academic performance, that goes without saying, because if they are not able to keep concentrate in class, not able to pay attention, they are bound to have academic difficulties. They have memory issues. On the, like, physical aspects, they are very prone to accidents. They might be injuring themselves constantly. Again, like, differential diagnosis for ADHD, because we also know that hyperactive children are very prone to injuries. And there is increased incidence of anxiety in children. So, one of the take home messages is even asking for a very brief history about sleep, just asking whether the child is sleeping okay, is not an optional question. It should be incorporated as a routine questioning in all, like, child psychiatry cases. The learning objective of this session is obviously to recognize what is normal, what is abnormal, when do you refer for further assessment, what are the, like, what are the differential diagnoses, how to connect the various aspects. As a child psychiatrist, I always, when I'm training or teaching, I'm telling people that it is almost like a jigsaw, that, we are putting things into place and then making a huge, like, a proper picture. Unless you have all aspects covered, it's impossible to, like, come to a right diagnosis. And then management. As usual in child psychiatry, we go for more for a behavioral management than, like, pharmacological management. But I am going to touch upon some of the practical aspects about what the management issues might be. We know, like, now, especially, we know that the incidence of sleep disorders is increasing. We know children are on screens well into the night. Teenagers, if you ask any teenage child who walks into my clinic, and most of them will say we don't sleep before 2 or 3 in the morning. So it is more of a norm than, like, having a proper sleep schedule is more and more difficult in this day and age. But in classical, like, research papers, they have mentioned that usually normal developing children have about 25 to 40% problems with significant sleep problems at some point during their life, and increase that by 2 to 3 times for any child presenting with a psychiatric diagnosis. So recently there was a paper that was published which said that in a psychiatric OPD, when they've, like, asked about sleep problems, there was about 80% of children who had significant problems. So that's the magnitude of the problem that we are talking about when we are talking about 80 to, like, nearly 80% of the population of coming to our OPD. So majority of child psychiatric outpatient endorse a clinically significant sleep complaints. But the problem is we don't ask for it. So unless and until you ask for it, because the other problems are so huge, they are, like, parents are usually complaining about behavioral problems, or they're complaining about this child is, like, failing their exams or not being able to achieve their potential. that sleep somewhere doesn't take that much of an importance. That is why I'm emphasizing that we have to ask for it directly. Now, what is normal? For us to label it as abnormal or like, a problematic scenario, we also need to know what is normal. So, in a newborn, which usually we don't see in our clinics, but for the sake of 14 to 17 hours of sleep is something that is that is the norm. There is no daylight pattern. They might they might sleep during the day. Most of the time they're sleeping throughout the day. In infants, that is 4 to 11 months, so it's gradually reducing. As you can see, it's 12 to 15 hours. By toddler time, it's about 11 to 14 hours. And by adolescence, it should reach anywhere between 8 to 10 hours. And that is the norm. So that is where, we are anything other than that, you should, it is a problematic behavior. What are the classification for sleep disorders in children? So one is insomnia, that is less sleep. We all know about it. That is the most commonest presenting complaints, that they are either having difficulty in initiating sleep, so they're not sleeping. So anything, if they are trying to sleep for, say, 10 o'clock is their bedtime, if they are sleeping, not sleeping till 12, I always ask, are you trying to sleep? Are the lights off? What is happening? Or are you on the screen? Because then that is not what you're trying to sleep. But if there is an initiation delay of more than an hour to 2 hours, then that is that is something that is significant. And maintaining sleep. So constantly waking up in the night also comes under insomnia. There's sleep-related breathing disorders, habitual snoring, obstructive sleep apnea. Uh, and though rare, it is not uncommon in children to come with, especially with deviated nasal septum. It is common to or tonsillitis or adenoid swelling. They do present with snoring. The circadian rhythm disorders, that is, it's a delayed cycle. So instead of sleeping, they do get their 7, 8 hours of sleep, but instead of sleeping from 10 to 7, they might sleep from 4 to 11, 12 in the afternoon. And this we are seeing a lot in teenagers nowadays. And they're missing school because of that, or missing college because of that, unable to maintain a routine of sleep schedule. Then there is parasomnias, that is which are divided into the REM and the non-REM. We are going to speak a little bit more in detail about them. Movement disorders, restless leg syndrome, I think quite common if you specifically look for that, and the periodic limb movement disorder. And then there is hypersomnolence, sleeping too much. And narcolepsy comes under that. So we'll speak a little bit more about each of them. This is a very unique thing for children. It is not a psychiatric diagnosis, so you will not find it in ICD or DSM, but very, very commonly seen in a clinic setting. That there are two types of that. One is a sleep onset association. So they're usually seen in children on the spectrum or social difficulties, that they are so used to having a very strict schedule that they need those same rituals to go to fall asleep. So they might be used to their parents sleeping, mother sleeping next to them and rocking them and feeding them at a certain time and a certain way. And if that doesn't happen, they need their blanket, specific blanket, or they will need the specific bed, that, and anything other than that, they can't fall asleep. And the same conditions have to be maintained. So if they are going on a holiday, they find it difficult to fall asleep. If the mom is not present during mom is traveling, then those for a week or so, the child will not sleep. So it presents as frequent prolonged night awakenings, and it is most common in toddlers, under 3 age. And it is simply learned association. So because they're used to it, because they're the parents have not tried any variation in their sleep schedule or not even tried doing anything different. They are so used to it that there is a association now that you need A, B, and C to fall asleep. And the second time is the limit setting, most often seen in parents who lack boundaries. So, parents who are permissive, parents who will let their children get away with things. So, they find it very difficult to, like, be strict about a certain schedule for the child will present with, like, just when you want to switch off the light and it's time to sleep, they will come up with all kinds of excuses about not wanting to fall asleep. So they will come, they will, like, try to delay, they will try and come and chat to you, they will, like, just when you want to switch off the light, there is, like, they'll come and then start disturbing the parents in many cases. And the caregiver then has difficulty. Sometimes, there are both working parents, and finally the parents will give in and probably, like, give whatever the child is asking for. And that is where that reinforcement happens. Most commonly seen in preschool and school age children. And because of inconsistent parenting is the main issues. Now, both of these will work beautifully with a structured behavior treatment program or, like, very strictly adhered sleep hygiene. A little bit about the delayed sleep wake cycle. As we saw, like, the sleep times, which are normal sleep times, as you approach teenage, what happens is the physiological circadian phase delay begins, and that happens with puberty. So when a child attains puberty, the endogenous melatonin release shifts later. So the child before that, if they're used to sleeping, say at 9 o'clock in the night, as teenage hits, it becomes more and more delayed because there is also a physiological cause for that. But what happens in this case is that this getting this 7-8 hours of sleep, but it is just delayed. So they are unable to fall asleep at the conventional bedtime. And then it is like, because everything is delayed, they are sleeping at 3 o'clock or 4 o'clock in the morning, and then they can't wake up in the morning for going to college or school. How do you differentiate that between, like, because what sometimes they present with, they will not, like, parents will not come and say that they are not sleeping appropriately. They will just come and say that this child is refusing to go to school, or they might present with oppositional behavior. Often, like, because they're spending daytime in their bed, they might also present with, like, depression like symptoms, saying they don't want to get out of bed, and, like, they're isolating themselves. All of that, sometimes presenting complaints are different from just sleep. The key differentiator here is that the quality and the quantity of sleep is enough. So they are getting their 7-8 hours of sleep, and it is undisturbed sleep. So once they get that kind of sleep, they don't wake up tired. They don't, like, so on the weekends, for example, when no one is waking them up, they're perfectly fine. But on the days that they're supposed to be going to school or college is where all of this problem starts. So some easy, like, hands-on management for this kind of problem is, as soon as, like, at 7 o'clock or 8 o'clock when they're supposed to be waking up, make the room very bright. So tell parents that as soon as they wake them up, the curtain should be off. There should be bright light, and, like, there shouldn't be a possibility of them going back to sleep. Similarly, like, you during when they are supposed to be going asleep, make the room, make the environment such that, like, the body automatically gives you a signal that it is time to go to sleep. Low dose melatonin, but however, in, like, at the right time, which is very important, works in this case. And what happens is, if the child is used to sleeping at 4 o'clock every day, suddenly one day you can't wake up and tell, now today you're going to go to bed at 10 o'clock. It is a gradual shift of about an hour every week. So if the child is sleeping at 4 o'clock, you aim for 3 o'clock for a week. Then, so it can't be like, that overnight it's going to change. It is a very gradual process. The second was sleep disordered breathing and obstructive sleep apnea. So, what happens is, usually, as I mentioned, in the age of 2 to 8, mainly due to, adenoids or tonsillar hypertrophy. So if they have tonsillitis or adenoids, that is when the child very easily commonly presents with sleep apnea or snoring. Deviated nasal septum, DNS, is another cause where we see snoring and incomplete sleep. So they're waking up tired. They're not like, the constant awakening in the night. This is also associated with like, obesity because they are not getting their sleep. The core symptoms are habitual snoring. Like if the parents observe it, it is very alarming for them that like, the child suddenly is snoring and then stops breathing for a second or two and then comes back to sleep. They Parents will also complain that they sleep with their mouth open, so there is mouth breathing, and there is a lot of restlessness. So they are like, they don't have a very well rested sleep, so they get up tired in the morning. Daytime presentation can mimic or worsen ADHD. So they present classically with inattention, not being able to concentrate for prolonged periods, hyperactivity, irritability, and behavioral dysregulation. The first line of treatment is treat the cause. So adenotonsillectomy in most children. Refer to an ENT. Like, it's always better to get an ENT assessment done if there is sleep apnea that is suspected. And an EEG confirms the diagnosis. So EEG is one of the like go-to uh, thing that if we are suspecting either epilepsy or sleep apnea, because it is very classical picture that we see. Then there are parasomnias, the REM parasomnia and non-REM parasomnias. The non-REM is usually seen in the first one third of the night. So, like, just immediately falling asleep, and vis-a-vis the REM parasomnias are in the later half of the night. Sleepwalking, sleep terrors, and getting up confused is like, falls under the non-REM. What happens is the child is almost partially awake. They come with, I can't wake up, but it is that there is a partial arousal state and they don't remember in the morning. So these complaints are usually from the caregivers, mostly parents. They will come and say, this child was sleepwalking. The child will never complain about either sleepwalking or sleep arousal or sleep terrors. It is the parents who will like, suddenly this child is awaking with like screaming in the night, or they are walking into the child has no memory about it, and it is usually seen in preschool and school, and by teenage they have outgrown it. um, any kind of stressful environment, fever. So when a child presents, the first thing to ask is, has there been any change? Like, has it been triggered by something? It could be that the child was unwell just prior to these episodes starting. It could be that, child has traveled and there was jet lag, which is very common in these cases. Or there has been a stressful event or ongoing stress in the child's life. The REM parasomnias are mainly nightmares. A child would wake up and remember that, like, he or she had a nightmare. The child wakes up completely aware about what is happening. They will come and tell you, I had a nightmare about, say, a ghost. Like, a lot of times I get children complaining that they are lost somewhere. Their parents are like, their parents have left them somewhere, that they are on a train. I had a child who used to have constant like nightmares about abandonment, that he was abandoned somewhere and like there was no one when he woke up. Very commonly associated with anxiety. If you take a detailed history, usually there is some kind of trauma exposure. And nowadays the trauma exposure doesn't actually have to be something that the child is subjected to. I have seen a lot of children who have actually seen something on social media, on television, and that has which was not age appropriate, and that has traumatized the child. So please, sometimes the parents will say, nothing happened. But when you ask the child, they will like, in confidence tell you about something that they have watched, which they were not supposed to be watching. And acute stress, that is where it usually comes across. Uh, and whenever a child has a persistent pattern of nightmares with a consistent traumatic theme, please go back and like, look for PTSD. Restless leg syndrome and periodic limb movement disorder. Now, this is a very uncomfortable urge to move the legs. Happens like in the evening or when they're resting. Anytime the child goes to sleep, even during the nap time in the afternoon, they might complain that like, the child is constantly moving their legs. And it is relieved by movement. So if the child wakes up and has a little bit of like, he goes and has a round, comes back and goes back to sleep. It can be described as growing pains and or show up as gentle motor restlessness. Again, very like, it if you don't specifically have this in mind, could be confused with like hyperactivity. Um, the periodic limb movement disorder, very, very rare, but it is repetitive stereotype limb movements only seen during sleep and identified on EEG. So that like, the EEG pattern again is very classic. Narcolepsy. How it differs in children is that obviously narcolepsy is characterized by excessive daytime drowsiness despite adequate sleep. So they are sleeping well into the night. They have the parents say they sleep well. There is no like, disturbance during the night, but still they are sleeping during the day as well. They can't stay awake is one of the complaints that the parents will come up with. There is a sudden loss, so cataplexy, which is the sudden loss of muscle tone triggered by strong emotion. That is a classic thing that happens whenever there is a shock. There is like acute stress. The child just collapses. In children, how it differs slightly is they might not have like a complete collapse. They might have a partial, subtle changes which could be a hypotonia of the facial muscles. So they could just be like, a child came with a frown, constant frowning, which happens periodically. There might be trunk protrusion rather than a dramatic collapse that is seen in adults. Uh, with behavioral change, sudden change in behavior. The child was very like, soft spoken and obedient, and suddenly like, has become very irritable. Good in studies and like started failing in exams. Misdiagnosed initially a lot of times with depression because they present with a change in behavior and they present with declining school performance, no interest, like, spending time in bed. So it might be misdiagnosed or differential diagnosis of depression, a learning problem, or even absence seizures. Now, what we see commonly as child psychiatrists is ADHD, autism, neurodevelopmental disorders. So it's very interesting to see the play between sleep and ADHD, for example. It is a very bidirectional relationship that it is, because poor sleep can mimic or worsen inattention. So if a child is having the primary problem is insomnia or restless sleep, during the day they present with inattention, difficulty concentrating, and that is a presenting complaint. We also know that ADHD itself, and the primary diagnosis is ADHD, sleep is a secondary, it does get affected because of circadian delay, insomnia. ADHD and restless leg syndrome, also there is a higher incidence than in normal population. A substantial proportion of children with ADHD have like sleep problems. They will not be able to sleep, and most parents complain that like, God, they find it really difficult putting this child to sleep. We also know that stimulant medication, methylphenidate, one of the commonest significant side effect is that it affects sleep and appetite, but sleep is very common that it gets affected. And so it is very important that when you're prescribing methylphenidate, that you warn the parents that it should not be given after a certain time. In my clinic, I always say that, like, at the most you can give it by, like, 1 o'clock. Don't delay it more than that because sleep will get affected unless there is a specific need for the child to study into the night, which is then, like, exceptional cases that you think about it. But in normal scenario, you always tell the like, if you have not taken it by 1 o'clock, if you have missed your medication, then do not give it that day, because otherwise the child is not going to be able to sleep, especially the longer acting ones. The shorter acting ones are 4 hours, so they can be given, like, in the evening, but latest by 6 o'clock. Screen for obstructive sleep apnea and restless leg syndrome before attributing all symptoms, like, restlessness to ADHD. So do not jump to the conclusion that just because a child is inattentive or restless, that it might be ADHD. And improving sleep can meaningfully reduce ADHD symptom even when the diagnosis is ADHD. If you do if the child has a proper sleep schedule, you know that, like, the inattention is substantially improved by having a good sleep pattern. Sleep and autism. A large majority of children with ASD experience significant sleep disturbance, and it is the highest in any presentation that ASD and sleep problems are there is a highest incidence. The common pattern seen in children with ASD or those who are on the spectrum is that there is a prolonged sleep onset latency. So there is a delayed onset of sleep. There's frequent night wakening, there's early morning awakening, and there is a irregular sleep wake scheduling. So they are sticklers to, like, sleeping at a certain time, or and need their certain environment to fall asleep. But otherwise, there is a lot of sleep issues contributing to the ASD. There is a physiological reason, and that is because in ASD, there is a disrupted melatonin production as well as regulation. It could also be because of the sensory difficulties that they have. So, like, the pillow has to be a certain way. If the blanket touches them in a certain way, they wake up in the night because they are so sensitive to certain touches and certain, textures. The bed, if it becomes lumpy, or, like, so even little things, it just has to be a certain way for them to have, and that can be really, really difficult. Co-occurring anxiety, again, anxiety, depression, there is a higher incidence in children with ASD, and that affects sleep, paradoxically. Behavioral intervention tailored specifically for the child's sensory profile, along with melatonin works, is the first line of treatment. And addressing the sleep um, environment, like, the light, the noise, the textures, all of that, if you put that, just reduces the our pharmacotherapy need in such children, because they're also, what happens is ASD children are also prone to side effects much more than normally developmentally children. Um, Sleep, anxiety, and depression. I think this we all know that insomnia functions both as a symptom and an independent risk factor for anxiety and depression. So if you have sleep disorders, if you're not able to sleep, you're more prone to develop anxiety and depression, and vice versa. If you have anxiety and or depression, you're likely to have sleep issues. Nightmares and difficulty initiating sleep are common features of young children with presenting with anxiety or PTSD. Persistent childhood insomnia predicts later onset of mood disorders. So if they have prolonged problems with sleep, you also want to look at, like, what their life expectancy in terms of, like, later development of mood disorders might happen. Uh, treated by CBT in children with anxiety, depression, and sleep issues, and improving the sleep hygiene measures can definitely act. If not treat the mood disorders, it will definitely be an adjunct to your pharmacotherapy in these cases. I just wanted to touch briefly on the bidirectional sleep and psychiatry relationship. There are certain sleep problems which will cause psychiatric symptoms, and there are certain psychiatric problems which will cause sleep problems. So, just wanted to briefly touch on that if there is obstructive sleep apnea, the presenting complaints will be inattention, irritability, behavioral dysregulation, which, so if there is a child who's presenting with all of this, one diagnosis to keep in mind is OSA. Insomnia presents with anxiety, depression, or mood dysregulation, which as they're getting into teenage, that is what they will present with. Circadian delay often presents with school refusal because they are unable to get up in the morning to go to school. It might present with oppositional behavior. A lot of times the parents will just say they're refusing to go to school or they are acting really, really stubborn. Restless leg syndrome presents with poor concentration and irritability. And narcolepsy will present as apparently symptoms of ADHD, depression, or behavioral problems. And vice versa. ADHD, the problems in sleep is that there is a delayed sleep cycle and it might present with insomnia. Anxiety comes with delayed, like difficulty falling asleep. Depression may present with either sleeping too little or sleeping too much, spending most of their day in bed. Bipolar disorder, we know that there is a decreased need for sleep. So they do not feel that they need to, why waste time sleeping? I have so many plans that I need to, bring to fruition. ASD presents with insomnia and circadian rhythm problems, and PTSD is associated with nightmares and night awakenings. Treating the psychiatric diagnosis without treating the sleep disorders. So, especially when you're facing that you're treating everything that you're supposed to. So, in a case of anxiety and depression, if you're treating that, but there is still something that feels amiss. There is still, in spite of the right dose, the right duration, there is there is a resistance to treatment. Go back to the drawing board and ask about sleep. That is one of the commonest, things that we miss. Psychotropic medications and sleep. I've already spoken about stimulants, about how they delay sleep onset. There is a reduced total sleep time, especially with late dosing. SSRIs might cause activation. So you usually start SSRIs in the morning or insomnia, and they cause occasionally they might cause vivid dreams. Alpha 2 agonists like clonidine are sedating. Atypical antipsychotics, we all know that they cause sedation, weight gain. They can also, over time, raise the risk of obstructive sleep apnea. Bupropion can worsen insomnia, and melatonin is the gold standard, but it is generally well tolerated. However, you have to be careful about the timing that you give these medications. Simple 5 questions to ask in a very busy OPD. It doesn't take that long. But if the child is presenting with sleep problems, just ask when does it happen? So what time does the child actually fall asleep and what time do they wake up? How long does the sleep take, to by the time they go to sleep and they're falling asleep? What is the gap that is there? How often is the sleep interrupted? Is there any kind of snoring, gasping, movements, nightmares that happen during the night? Is there daytime drowsiness, sleepiness, daytime naps, especially in older children? And the context. So it's very important to find out about because this is the commonest thing that we see nowadays, that the children are on screens. They are like, either they are sending reels to their friends, or they are like, and we all know that screens are awakening. So is it related to screens, that, oh, the child is trying to fall asleep for 5 minutes, can't sleep, immediately they get their phone and start like, scrolling. So it's a vicious cycle. It could be related to caffeine. Children nowadays are having a lot of coffee or Red Bull. So asking about those things. What is the school schedule like? What are the medications they are on? Any stress, any change in the family environment or family routine. So simple questions that you can ask in your OPD. The commonest assessment tools, I personally use the sleep diary. I don't use like, the others, but there is one very easy to remember Bears tool, which ask about bedtime issues, excessive daytime sleepiness, awakening, regularity or duration of sleep, and snoring. So it's like, the 5 things to ask briefly in children. There is also a questionnaire that you ask parents, but as I said, I use a very simple, give me a 2 week. I send the child back and the parent back to say, for the next 2 weeks, just tell me and actually write in a diary about what time you went to sleep, what time they woke up, how many times they woke up in the night, and then we will chat about it. In terms of objective testing, it is asking if you suspect, like, restless leg syndrome, or you suspect obstructive sleep apnea, ask for an EEG. Vitamin D levels, I have seen a lot of currently, and that is why I put it out there, that there are a lot of currently, we all know India being a tropical country, there is an endemic deficiency in spite of the tropical climate that children are having. And what vitamin D deficiency presents with is that they're tired all the time. So they're sleeping during the day, they are unable to get out of bed. So simple things. When I ask for routine blood tests, I also ask for a vitamin D screening in all children nowadays. I know there are a few questions, I think, but I'll come to that. I'll quickly finish the management part of it. So first line, always in children, is non-pharmacological. You don't jump to, medications. You always first try the non-pharmacological methods. uh, One is like, the sleep hygiene. They need to have, all children need to have a consistent sleep wake schedule. During the weekends, it can be a bit more relaxed, but it can't be that, they're waking up at 7 o'clock in the morning. They need to wake up at 7 o'clock in the morning for school, and then they're suddenly waking up at 12 o'clock during the weekends. That's just making life like harder for the parents. A calming down routine, keeping your phones away, keeping your screens away at least an hour before you want to fall asleep. So I tell all parents, please take away their screens 1 hour before you want to put them to bed. There has to be, and that, take the screen as in take the phone away and put it in another room, because don't keep the phone in the same room as the child, because there is a high propensity that they will go back to it. Listening to calm music, having a glass of like, warm milk, hot water baths in the night time if you're having problem, because that really helps you calm down. Making the room, dimming the lights, like, asking the child to start reading. Half an hour of reading just before falling asleep is a great way of making the child fall asleep. So changing the environment, and like, having some routines that are calming during the night is very important. Reward system, again, like praising the child, giving them small tokens. Children are usually like, you don't have to give them lots of uh, that is one of the mistakes that parents do, that they give them a lot of expensive gifts. No, all the child is looking for is validation from their parents. So consistently praising the child for sleeping on time is valid enough reason for them to fall asleep. CBT, especially in adolescence, for like tackling sleep problems. Light-based interventions, so bright light in the morning as soon as they wake up, for especially for the circadian rhythm disorders, and behavioral treatment. So mainly that is like, the thing that we go for. And they have to be consistent about it. So they can't come back and say, we did it, we tried it for 2 nights, didn't work. It has to be like, right at the beginning, say you have to do it a minimum of 2 weeks consistently to be able to see any kind of difference. What are the pharmacological options? Like, first and foremost, identify and treat the underlying cause, like try behavioral and environmental interventions. Pharmacotherapy, if used, should be used short term, not a substitute for behavioral treatment, and the lowest effective dose. Most of the medications, other than melatonin, are like, in children are off label. Melatonin is if you're treating, if everything else fails, you can try melatonin in children. It comes as either like, it is safer in children. It is an endogenous hormone already produced in the body. It regulates sleep cycle, and it like, the potential uses are in cases of circadian rhythm. So if they're sleeping, delayed sleep cycle, insomnia, children with autism and or ADHD, starting a dose of 3 milligrams in immediate release, if it is sustained release, and 5 milligrams is the minimum dose, given 30 to 60 minutes before the child needs to go to bed. And usually start with immediate release for onset problems and delayed release for maintenance, when maintenance of sleep is a problem. Please monitor once you start it. I usually give it for a week to say reset the cycle. It's almost like, resetting and then stopping and trying again without medication. But monitor for morning sedation, headaches, dizziness, and any kind of behavioral changes. So once they come back, please ask for this once you start giving them melatonin. Other pharmacological, like, treatments could be antihistamines, that you can give, like diphenhydramine or hydroxyzine. Comes in syrup formation, which is always like, a benefit for younger children. But the problems with that is that tolerance can develop. There can be daytime sedation. In some rare cases, it might cause paradoxical excitement. And there can be a potential toxicity in overdose. So you have to tell the parent that you are the one who's going to be, even in teenagers, I usually say make sure, because you never know whether the teenager is taking it or not. It's also for compliance sake, I tell the parents, like, please monitor the medications that they're taking. The other options are clonidine, which is used for sleep problems, particularly in children with ADHD, because it also paradoxically reduces hyperactivity in children. It calms the children down, but the adverse effects are sedation, hypotension, bradycardia. So you have to, like, monitor their heart rate once you start clonidine. And one of the major issue is that you cannot abruptly stop clonidine, and you have to warn the parents about it, that it can cause dangerous spikes in blood pressure. I cannot emphasize this enough, because in India, unfortunately, parents have this thing about, like, just suddenly stopping because they don't want to. The problem is solved, so they don't want to come back to the doctors. ठीक हो गया अभी, like, we are stopping it. Just make sure that you mention it before starting clonidine that this can't be done. I have sometimes used, like, for example, mirtazapine for sleep issues and depression. You use the side effects of some of the medications to your benefit. So if you have, like, we all know that mirtazapine is a sedating antidepressant. So you look at a child who is not eating, a child who is not sleeping well, both are benefited by mirtazapine. Benzodiazepines and Z drugs are not, like, indicated. FDA has not approved. In fact, there are a lot of potential side effects in children. So, like, not used in children at all. other than very, very short term. For example, clonazepam can be given for, it can't be given as a routine. It is just SOS in very severe cases. I use olanzapine smaller doses and quetiapine, like, 12.5 and olanzapine 1.25 in cases of behavioral problems, like, severe behavioral problems in children, or like mood instability, dysregulation. I have seen that a small dose of atypical antipsychotics like olanzapine or quetiapine does help in these cases. So just summarizing what we spoke about, that screen for sleep disturbance, just ask about sleep problems in all cases of children that you see. Because, as I said, parents might not raise it as a concern. Characterize the complaint. Is it an onset problem? Is it a maintenance problem? Are there breathing issues? Like, is it a delayed cycle or is it parasomnia? Just like, mota, make sure that you're categorizing in which sector it comes under. Rule out red flags like snoring, any, like, apnea, injurious movements, especially during sleepwalking, and then refer appropriately. Start behavior therapy as the first line of treatment, melatonin if indicated, and then reassess any psychiatric symptoms once sleep is improved, especially in anxiety, depression, or inattention. So that was my, like, presentation. I'm just going to stop and then we can take questions. Sorry. Right.
Yes. Thank you, Dr. Sapna. I think it was a very insightful and a very elaborative presentation covering all theoretical and practical aspects as well as the management part of it. I'm sure it has been useful for all of us. There are a few questions in the chat box. I think we should take them one by one.
Sure.
One of the question is how to manage sleep bruxism in children if no stress factor is found. So what is your take on that?
So sorry, I think I have seen that, like, they have mentioned guards and all of that, but
Hmm.
a small, like, small dose of melatonin before sleep helps a lot in bruxism. But yeah, if it is really, really severe, then referral to an ENT, and the sleep, like, that guard, the mouth guard helps a lot, especially if it is very injurious. But from our point of view, I think melatonin helps a lot. 3 milligrams of melatonin works wonders.
And there are other questions on melatonin, like what up to what dose we can give, and does it help in nightmares in the children?
It helps in nightmares. Melatonin in children, like, is 3 to 9 milligrams immediate release is something that is indicated. But I have seen practically off-label people taking, like, higher doses, up to 18 milligrams as well. But depending on the age of the child, please try with, like, 3 milligrams first and then gradually increase. As per the, like, the guidelines, 9 milligrams is the highest that you can give.
How early it can be given? I think we can start as early as possible. Is there
Yes,
a
yes.
guideline?
Melatonin syrup comes, in fact, like, on Amazon, if you see, you get gummies as well. So younger children, like, colorful gummies are there. You can get it. It is not, you don't even need a prescription for melatonin. They can get it, like, on Amazon as well. So younger children, melatonin comes in syrups, gummies, and, like, tablets. So the younger you can give it in toddlers as well.
Yeah. Also, one of the question is if we are using clonidine for sleep purpose, how much dose it can be used with?
So it depends on the weight of the, like, child. So usually started with 500 micrograms, and then, like, it's 500 micrograms to start off. It not indicated in under 5 or 6, like, you can give it only after that. And it is weight related.
Okay. Dr. Sapna, I had one question from my end. So we have spoken a lot on insomnia, but a lot of times in adolescence, we see what is hypersomnia. So they want to sleep over more in the daytime, maybe just as a lifestyle or maybe an avoidance pattern from their commitments, or maybe secondary to depression also. But hypersomnia is more, I see in my practice, more common than the insomnia. So that is one thing. So how do we manage that? And in the management of hypersomnia, I've seen people practicing using armodafinil as one of the medicine for alerting. So what is your take on that management practice?
So I have very rarely use mode alert, like because if you take a child in confidence, they usually, as you've rightly said, they don't want to face their parents or they don't want to face others, so they sleep during the day and then wake up during the night, and they're doing all kinds of activities, being on the screen and all of that. So my first question is to, when I see adolescents, is to, do you want to change this pattern, or is it the parents who want to change the pattern? Because unless the teenager wants to change the pattern, that is not going to happen, whatever you try and do. Second is, identify the cause for it. So if they don't, mostly in hypersomnia, teenagers, adolescents, it is the lifestyle problem. They don't have a schedule. They don't go to college anymore. Most of it is online, so they can, they can get away with it. So unless and until a schedule is put into place, it is very difficult to manage. So I have, at least in my practice, mode alert I have given, but it's not been too beneficial because the child themselves don't want to, change that pattern at all.
Agreed. Yeah.
Yeah.
And if there is a comorbid ADHD, so does it have place in the management in that cases?
So in ADHD, in fact, it's the other way around. ADHD, they present with, inability to sleep. Most of them, most of the time, they are very hyper. And I have seen, unfortunately, because whatever said and done, when I tell them that methylphenidate should not be taken, the parents are so, no, they need to study, especially in the board exams and things like that. They are giving them well into, no, tuition ke time milna chahiye and things like that. So in fact, I use a lot of melatonin in these children or youngsters rather than mode alert.
Okay, thank you so much. Any other questions to Dr. Sapna? So I think it was very well taken by all of us. Anyone from the team who wants to speak? Dr. Manjiri?
Yeah, thank you, ma'am, Sapna ma'am. It was a very good presentation, and yeah, even people have interacted. I think melatonin is something that everybody generally has doubts about, etc. And of course, the nice takeaway messages at the end as to what to assess for, etc., are very practical, useful tips. So thank you, and thank you, Shubhangi ma'am, for the moderation. On behalf of the committee, yes, thank both of you for making it to today's presentation.
Thank you so
Thanks.
much.
Thanks a lot. Take
Thank
care.
you.
Bye
Thank
bye.
you so much. And good evening. Good night.
Yes. Good
Yeah.
night.